I'm going to talk about classic Ewing sarcoma today. A 16-year-old boy was admitted to our hospital complaining pain and swelling of his right femur since 1 month. He also referred a persistent low-grade fever and he denied any trauma. The physical examination revealed a palpable painful mass at the level of the right femur. There were, though, no abnormalities, so the consultant surgeon decided to take an NMR, and this is what the NMR showed. We can see that there is a 15 centimeter mass involving the diaphysis and the metaphysis of the femur and extending into the soft tissue. So an urgent biopsy was taken, and this is what the histological examination revealed. We can see that there is a neoplasia composed of monomorphous small blue round cells that are arranged in cords and trabeculae, and we can see that there is a fibrohyaline stroma. There were no necrosis, and trust me, you can see it, but the mitotic activity was really low. So since the age, since the typical localization and the histological features, we decided to perform some immunohistochemical analysis to confirm our diagnostic hypothesis. And as we can see, the CD99 showed a strong diffuse membranous pattern, and we also decided to perform ERG and FLY1, and you can see it from the image. The ERG showed a strong nuclear positivity. So a diagnosis of Ewing sarcoma was made. The patient was treated for 9 months with alternate courses of chemotherapeutic drugs, and then he undertook a surgery. This is what the histological response was. We can see that there are no residual tumor cells, and there is a total complete response. In fact, the specimen is completely necrotic. Now, luckily, the patient is well after 1 year with no metastasis or recurrence. So, we all know that Ewing sarcoma was firstly described in 1921 by Dr. James Ewing, and initially it was called diffuse endothelium of the bone, since the cells look like endothelial cells of vessels of the bone. Dr. James Ewing, in fact, understood that there was this new neoplasia different from osteosarcoma, but because it was responsive to radiotherapy, but it was really an aggressive neoplasia. We all know that is the second most common bone tumor in children. In fact, the median age at presentation is 14 years. Though we need to consider that it can affect also adults older than 40. And as we can see from this graph, we notice that there is a male predominance. Ewing sarcoma involve the bone. In fact, we can find axial skeleton is involved in the 45% of the cases. Instead, the distal skeleton is involved in the 45% of the cases. But of course, Ewing sarcoma can also have an extraosseous location. In fact, we can find it in the lung, in the thoracic soft tissues, and retroperitoneum. This slide is just to remind that a patient with Ewing sarcoma can present with or without signs and symptoms, and these signs and symptoms are really similar to those of osteosarcoma, but they differ in terms of frequency. What we can see is that we can have a local tenderness the presence of a palpable mass, and the patient can have pain, can refer also fever, and sometimes we can have also fracture. For the diagnostic path, it is fundamental to start with an Xray. In fact, it has some peculiarities, which, like moth-eaten pattern, which is characterized by small holes in the bone. And since it's quite an aggressive neoplasia, we can see also an intense periosteal reaction, which manifests with a typical Codman triangle or an onion skin aspect, or even with a sunburst appearance. After the X-ray, of course, we need to perform also an NMR because it's able to detect better the extension into the soft tissue and, of course, the relationship with adjacent structures such as vessels and nerves. And after the NMR, we need to perform also a CT scan because it's able to detect distant metastases, and they are an important prognostic factors. Nowadays, we do not receive any more specimens before chemotherapy, but what we could see is that there is a white solid mass involving the diaphysis or the metaphysis of the bone and infiltrates through the cortex and goes into the tissue. Of course, after the chemotherapy, what we are going to see is a more jelly consistency and a lot of necrosis and hemorrhage. I have already talked about the histological features of classic Ewing sarcoma. What I want to add is that, of course, these cells can be arranged in cords and trabeculae, but they can also have rosettes. And in our clinical case, we have rare mitotic figures, but I want you to remind that in some cases the mitotic activities can be high. The classical immunohistochemistry for Ewing sarcoma is, of course, the CD99. The CD99 is a quite sensitive marker, and it shows this diffuse membranous pattern. But of course, we all know that some other tumors can have also this pattern, and sometimes, occasionally, classic Ewing sarcoma can have a focal pattern. Of course, we can also perform ERG and FLY1, which are the typical genetic translocation, which are confirmed by the molecular analysis. But what is really important is now that a new antibody is being used in the last years. In fact, we can see this NKX2.2 that is quite useful for the diagnosis because it's quite sensitive. Unfortunately, it's not really specific because its nuclear expression is non-exclusive of Ewing sarcoma. But as you can see from this table, we can find the expression of this new antibody also in other neoplasia, such as cheeks sarcoma or unclassified round cell sarcoma, or even in mesenchymal chondrosarcoma. So it's really useful if we use it with the CD99, but don't use it alone. Of course, we all know that Ewing sarcoma has a typical genetic translocation that involves chromosome 11 and chromosome 22. That give birth to a fusion genes that in 80-85% of the cases is between EWS and FLY1, and in the 5-10% of the cases is a fusion genes between EWS and ERG. But what you need to remind is that, of course, there are other minor translocation. In fact, we can see from this image taken from New England Journal of Medicine that other genes such as FUSE and ETV can be involved. And what is really important is that these fusion genes act as a parent transcriptor factor because they can activate some genes with oncogenetic properties, but at the same time they can even repress some other genes with mechanisms that are still not really clear. So of course this means that they act with an epigenetic mechanism. So what are the main differential diagnoses to keep in mind? Of course, we need to consider the age, we need to consider the localization, but what we need to consider is, of course, the lymphoma, Xray sarcoma or big hole sarcoma, and of course, small cell osteosarcoma and mesenchymal chondrosarcoma. If we have a little child, don't forget about the possibility of metastatic neuroblastoma. So what to evaluate the histological response to chemotherapy, we can use now two scores. In the first one, we take in consideration the necrosis, and we can see from the table that there is a 4-grade scale with grade 1 with little or no response and grade 4 instead with a complete response. The other score instead is used for localized Ewing sarcoma of the extremities. This time we are going to consider the number of residual tumor cells, and we have a 3-grade scale with grade 1 with a lot of residual tumor cells and grade 3 with no viable tumor cells. So just to conclude, I wanted to remember what are the main prognostic factors to keep in mind. As we can see from this table, taken from this article published in 2018, there are some prognostic factors such as metastasis and diagnosis, the size, and the primary tumor site that have a strong level of evidence. Instead, others such as age and site of metastatic lesion have an intermediate level of evidence. But what is really important is that in the last years, of course, the overall survival of Ewing sarcoma has increased. In fact, we can see from this table that the overall survival is different according to different features such as sex, age, and tumor site. In general, what we can see is that in 1973, the overall survival for localized Ewing sarcoma was 40%, and for Ewing sarcoma with distant metastasis were 15%. Now, as we all know, the overall survival is 70% if we have a localized Ewing sarcoma, and is just unfortunately 30% for Ewing sarcoma with metastasis at the first diagnosis. So what are the take-home message? Of course, it is the second most common primary malignant bone tumor that affects children, but it can affect also adults. The diagnosis is confirmed by histopathological and immunohistochemical analysis. Sometimes we can also use the molecular analysis. Patient can present with signs and symptoms, and unfortunately metastases are usually present at the time of the diagnosis. Thank you.